So thanks for having me. I know Dan Pett mentioned I was going to be talking a lot about molecular therapy, and I think I'm going to be disappointing him just a little bit on kind of what we have available. But so to start, so I don't think anyone this morning mentioned the BCLC staging system, but this is the Barcelona Clinic Liver Cancer Staging System. That's kind of become the de facto staging system because unlike staging other cancers, right, we have to take into account the patient's underlying liver function. So this is not a perfect system, right, but it takes into account looking at the patient's tumor characteristics, their Child-Pugh score, their performance status, and then the tumor characteristics, and putting that together into kind of a basic treatment algorithm. And so we move from the left to the right, from curative intent treatment, which we'll be hearing about a little bit later, resection, transplant, potentially radiofrequency ablation, moving toward patients with local disease who are going to get usually IR or radiation-directed therapy for localized tumor, right? And then from the time that I came to Yale and started focusing on this disease, right, this is kind of where medical oncology is, right before symptomatic treatment, palliative care. So we have this little kind of narrow window. And at the time, since I finished training, right, we've had one approved drug in liver cancer, and that's been sorafenib. So I think we're all familiar with the SHARP study, and that was the original positive study in liver cancer for systemic therapy, looking at sorafenib versus placebo in patients with advanced disease. And similar to kind of the characteristics that we look at, that we'll go through in the other clinical trials, all patients had to have good liver function, and we'll go through some of the other characteristics that are usually included. And this showed, right, an overall survival benefit that went from 7.9 months to 10.7 months. And while that may not seem like a large difference, right, this was really exciting that there was finally a positive study with systemic therapy. And this just shows that there was also a time rate to radiographic progression. And so based on that, sorafenib was approved by the FDA. After that, then over the next several years, there were multiple negative studies, of which I'm not going to mention, right? But it's not for lack of trying. But over many years, there were no new approved drugs for HCC, you know. And so when we think about, right, what is sorafenib doing, and we think about a lot of the new drugs that have come along that are in the same family of multi-tyrosine kinase inhibitors, or TKIs. The truth is, right, they're kind of acting on a bunch of pathways, and we really don't know what the maybe most effective pathway is that's kind of giving us the survival benefit that we see in these patients, right? But it's targeting multiple pathways, RAF, MEK, ERK, PDGFR, et cetera, VEGF. And so I would say, even though we keep seeing these small benefits, right, in TKIs, we don't exactly know which pathway is kind of causing the survival benefit. And so then the next drug that came along was Regorafenib. It's a very similar drug to sorafenib, another tyrosine kinase inhibitor. The molecular structure is almost identical, except there's a fourth fluorine group on the end of Regorafenib. There's only 3 on sorafenib. So I don't think that going into this study, right, a lot of oncologists thought that it would necessarily be a positive study. So this was the resource trial. Patients were randomized because there was nothing approved in the second line. So like most of these studies for second line, patients were randomized to placebo. In this study, they were randomized 2-to-1. And so this had to be for patients who tolerated sorafenib in the first line, which meant they had to at least be on a dose of 400 milligrams a day. So that's half of a full dose. Because the side effects are so overlapping that if you didn't tolerate sorafenib in the first line, you probably wouldn't tolerate this. They all had Child-Pugh liver function. Over 500 patients went on the study, and the primary endpoint was overall survival with a bunch of secondary endpoints. And again, it showed a median survival of 7.8 months to 10.6, so kind of similar to the survival benefit that we saw in sorafenib, right, but this is in second line. And if you look at the subset analysis, so a lot of these studies kind of look to see if there's a difference in patients based on their AFP level, based on the fact of whether they had extrahepatic disease or macrovascular invasion, and also, of course, whether they had hepatitis B, hepatitis C, or non-viral etiology, right? And if you look at, for all the subset analyses, they all favored Regorafenib. And so then this drug was also approved a couple of years ago. More recently, there was a study with lenvatinib, another oral tyrosine kinase inhibitor, and this was the REFLECT study that was designed to be a non-inferiority study against sorafenib. So basically, they were looking at survival. This was a large global study, phase 3. So almost 1,000 patients went on this study. So this was first-line treatment, and again, for kind of similar patients with BCLC stage B or C disease, Child-Pugh A disease, good performance status. And they were stratified by region, so Asia Pacific or Western, whether they had macrovascular invasion, extrahepatic spread. And they received either lenvatinib, this was a 1-to-1 randomization, lenvatinib or sorafenib, with a primary endpoint of overall survival. And if you look at the outcomes, the overall survival was basically the same with a hazard ratio of 0.92, so it met its statistical endpoint and was considered non-inferior. In terms of the PFS rate, it does look like the PFS is a little bit higher with lenvatinib, but to keep in mind that was not the statistical endpoint of the study. And interestingly, the response rate on this study was 9% in sorafenib, which is kind of high for sorafenib, because even in the SHARP study, there's like about a 4% response rate. But the response rate in the lenvatinib was 24%, which was surprising how high it was. This drug was now also approved in first line as an alternative to sorafenib. And so I think the question often comes up of, why do you pick one drug over the other? The survival benefit seems to be about the same. The response rate seems higher. In terms of side effects, right, the adverse event profile is a little bit different. So more diarrhea and hand-foot reaction with sorafenib, but there's a little bit more encephalopathy with lenvatinib. I would say I think a lot of places now are adopting lenvatinib over sorafenib, and I think over time we'll probably see more data in the community about how patients are kind of faring on lenvatinib and what the side effect profile is when we start giving it to patients who don't necessarily fit the clinical trial criteria, like the Gideon registry that was collected after sorafenib was approved, kind of seeing in real time how patients with Child-Pugh B disease do, which is a lot of the patients that we treat, right? We don't have that data with lenvatinib yet. Then, of course, excitingly, we think about immune therapy in HCC and kind of all the potential pathways that we could be looking at, PD-1, PD-L1, CTLA-4 antibodies, thinking of our VEGF inhibitors and how that may affect the microenvironment and improve response to immune therapy. I think HCC overall has been a little bit late to the game of immune therapy, and there's probably a few good reasons why companies were, I think, a little bit scared about starting trials in HCC before their drugs were initially approved for another indication. Few reasons. One, because in general, usually having a viral infection like hepatitis B or C is exclusionary for a clinical trial, right? And for HCC, it's vitally important that we include these patients on our clinical trials. And then, of course, because of autoimmune-related events, right? So you would imagine the concern for giving a patient an autoimmune hepatitis from treatment would be considered that much worse in a patient with underlying liver disease. So looking at the data that we have, so one of the first studies looked at Nivolumab from a phase 1 study in HCC. So this was kind of one part of the study, the PD-1 inhibitor, and this included patients with Hep B, Hep C, and non-viral etiologies, and the spots were kind of separated out, right, by infection, because there is a large concern that there might be a real safety signal in these different groups, right, or potentially different response rates. And as you can see from this plot, so looking at months on treatment, right, so this was the sorafenib untreated or intolerant. So this was kind of the first-line patients. Then these were second-line patients who had been progressors on sorafenib without viral hepatitis. Then these are the patients who have Hep C and Hep B. And you could see that overall, right, the patients stayed on treatment for roughly about the same amount of time. And then looking at the waterfall plot in terms of responses, right, you could see that these look almost superimposable on each other, so that we see, and this 30% cutoff here, right, is our RECIST criteria for partial response, and then greater than 20% here is progression. So you could see that basically looking at the responses, they seem pretty identical across the 4 groups. So we don't really see a difference based on viral etiology and who's responding to immune therapy. The other thing I would say, going through all these immune therapy trials, one of the things that's come out too is that it doesn't matter if they test for PD-L1 positive or not. So even though we have the ability when there's a biopsy to look at that, unlike in some cancers where the FDA indication based on the data is for only treating patients who have PD-L1 expression at different cutoffs, the responses that we see to immune therapy with HCC are, do not correlate at all with expression. And so this is just a spider plot, again, just kind of showing the responses that we see in length of time patients were on treatment, and they are very similar. And basically, we saw about 19% response rate across all etiology. And so based on that, Nivolumab was the first drug approved for second-line therapy in HCC. Next, then we had the Keynote 224 study. So this is looking at Pembrolizumab, kind of very similar trial design to the Nivolumab study. Same group of patients, basically, and they got Pembrolizumab. And they assessed response every 9 weeks. And again, the primary endpoint was response. And the data is very similar from this study to the Nivolumab data. So basically, the response rate was just about the same. And just something to think about, because I'm always asked at Tumor Board kind of when we start patients on treatment and if they have an early scan or we're looking at their AFP, how long should we have people on treatment before we kind of say whether the drug is working or not? So just as an example, and the data from the other studies are pretty similar, right? So the median time to response for this study was 2.1 months, and the time across these patients looking at response rates, so the earliest response that they saw was at 1.8 months, and for some patients it was significantly longer than 2 months. And again, looking at Pembrolizumab response across etiology, the data, again, is very similar to the Nivolumab data. I think this got overlaid a little bit. But overall, right, we saw responses across all 4 patient groups in similar percentages. Now, unfortunately, so just last week, the company announced that the data from the Pembrolizumab versus best supportive care, the Keynote 240 study, was negative. And that's certainly a disappointment, and that was just kind of announced last week in a press release. So I don't think the data hasn't really been parsed over yet. But in this study, over 400 patients were randomized to Pembrolizumab in best supportive care or placebo in best supportive care. And unfortunately, the study did not meet the overall survival endpoint or progression-free endpoint, so with non-significant p-values. The response rate for this study wasn't reported, and we haven't seen all the data. I'm sure we'll be seeing it at an upcoming meeting. I guess the question is now, so the FDA approved Pembrolizumab in the second line based on the phase 1 data, and I think, the expectation was that we would see this confirmed on this study. And now that it's not, I'm not sure what would happen to the approval, although we will be seeing other data with Pembrolizumab in combination therapy with TKI, so we'll see if that data is positive. But of course, this was disappointing to see. So going back to some of the other positive studies that we've seen in HCC, so ramucirumab, another VEGF antibody. So this had been looked at initially in the REACH1 study, looking at second line. And again, when all these studies were designed, nothing was approved in the second line, so they're all randomized to placebo. And initially, they looked at patients regardless of AFP value with prior sorafenib, kind of otherwise, good prognostic indicators with ECOG performance status and Child-Pugh score. And they were randomized to ramucirumab plus best supportive care versus placebo. And the REACH1 study was negative, but then when they looked at a subset analysis, it looked like there was a signal in the patients who had an AFP greater than 400. So they went back and did a second study, the REACH2 study, that only focused on patients with an AFP greater than 400. So in this study, patients were randomized 2-to-1, and by macrovascular invasion, geographic region, looking for a survival endpoint. They predicted 4.5 months going up to 6.7 months, and they did reach the endpoint for this study. And if you look at the survival, so the survival for the patients on ramucirumab at 12 months was 36 so not far from the placebo group, but it really separates out more. So out at 18 months, it's a difference of 11% versus 24. And so this is another option of drug for patients. I would say the main difference potentially between using this drug versus a tyrosine kinase inhibitor is that for patients who may not be tolerating a tyrosine kinase inhibitor at all from side effects, right, this has a different side effect profile, but we have to only be thinking about the patients with a high AFP. I think the question is, right, what is different about a patient with a high AFP? Is the biology really different? Are we thinking about it, that the mutations in the tumor might be different, or are we just saying that this maybe pulls out a more aggressive phenotype where it's easier to see a survival benefit between treatment versus placebo? I don't think we know the answer to that. So another second-line study with a tyrosine kinase inhibitor, it's a common theme. So this was the Celestial study that looked at Cabozantinib. Again, in similar patient population, over 700 patients were on this study. They were randomized 2-to-1 to placebo and had tumor assessments every 8 weeks. And there was an increase in progression-free survival in this group, but like we see, so here, right, we only see a 4% response rate, but the majority of patients, right, 60% had stable disease on treatment. And there's a good separation of the curve. And again, for overall survival, there's a difference of 8 months to 10.2 months for the median overall survival. And so Cabozantinib was just approved. So if we look at kind of, so this is I think, a good snapshot of kind of where we are right now in terms of drugs that are approved, right? So back out here, we have Sorafenib approved more than a decade ago, negative studies, no approvals. And then the next positive study was Regorafenib that was just approved in April 2017. Then we have Lenvatinib, the non-inferiority study in first line, Nivolumab, Pembrolizumab, and then just Cabozantinib approved a few weeks ago, right? So that's kind of a current snapshot. So we have our tyrosine kinase inhibitors, and then we have a couple of PD-L1 antibodies as single agents, all given for advanced disease patients who've already failed local therapy if they had been candidates previously for local therapy. So now in terms of thinking of, right, new options that we may have coming along for patients, so one of the studies I've been most excited about is a combination of Atezolizumab, another PD-L1 antibody, in combination with Bevacizumab, VEGF antibody that we use in other cancers. So we know it has anti-angiogenic effect, right, and HCCs can be very vascular tumors, but it seems like there's also an additional immune modulatory effect of giving a VEGF inhibitor with immune therapy. And so there was good kind of preclinical rationale for combining these two drugs. And so based on this, there was a phase 1 study that was done. This was a multi-arm phase 1 study, so there were other patient groups that went on the study, but we'll focus on arm A, which was the advanced HCC patients. So patients with Child-Pugh A or a few patients with B7 disease went on the study. They were given Atezolizumab and Bev every 3 weeks, and there was a plan for about 100 patients initially to go on the study. And the primary endpoint was safety and tolerability. This was a phase 1 study, and then overall response rate with a bunch of secondary endpoints. And so as of now, we have presented data on this study of over 100 patients for safety data and 70-something patients for efficacy. So if we look at kind of who went on this study, right, so predominantly men, as the HCC population is. A little bit more than half of the patients were from Asia, with the other half being Japan and the US. Even though they did include B7 patients initially, you could see that it was only a couple of patients actually with B7 disease, and almost everyone had Child-Pugh A disease. And about half were patients with Hep B. That reflects the Asian population. The majority of the patients had extrahepatic spread or macrovascular invasion. More than half the patients had an AFP under 400, and about half the patients had prior TACE therapy, and about a third had prior radiotherapy. And so initially, when we had presented this data at ASCO last year, we had a smaller group of patients that were assessed for efficacy, and the response rate was up to 60% in those first 30 patients, which I think seemed almost unbelievable to people looking at the data. And then as there's been more patients assessed, that number has come down a little bit, but it's still 32% response rate so far in 73 evaluable patients. So this is kind of the highest response rate that we've seen in any presented data yet for this patient population. So far there's been one complete response, and that's actually a patient that many of us have taken care of here, and that was pretty amazing. He actually had some issues with decompensation, and I took him off the study now about a year ago, and he still has no recurrence of tumor this past year, so that's been amazing. And then we have another patient in this partial response group who's had such a almost complete, it's almost a complete response, but they're still reading it as a partial response. And so there's been another 30 patients with a real PR, and these have been followed up on more than one scan. They've all had a confirmatory scan showing benefit. And then another 45 patients with stable disease, and 13 patients have had progression of disease. And so if you look by etiology in terms of the response rate, you know, they're evenly across all of the groups. I don't think you could really say there's a difference because there were only 2 patients on who were non-viral, so I don't think that's really interpretable. And then, right, we see responses across patients who've had extrahepatic spread or macrovascular invasion. Right, so it's a pretty impressive waterfall plot. And then this is just the spider plot looking at basically the same data and looking at, just in a different format, this is the disease control rate. So we're looking at complete response, partial response, and stable disease greater than 16 weeks is 66% of the patients, and greater than 24 weeks is still about half the patients. And so that's pretty impressive. And so far out of the 73 patients that have been assessed, we've met a median PFS of almost 15 months, and the median overall survival rate is so far not reached. And then we have the responders looking at, just looking at the patients who've had responses. The median duration of response has been more than 6 months for about half the patients, and more than 12 months for a quarter of the patients so far. And so, you know, this has really been pretty impressive, although the data is still early, right? The study's still ongoing. And this is just another form of that data. If we look at the side effects, so, you know, obviously we're most interested in the grade 3 and 4 adverse events. And overall, you know, they've been pretty low. I would say one of the more reassuring things that we've seen kind of across all the immune therapy data in HCC, we're not seeing a lot of autoimmune hepatitis, right? We're not seeing anyone die of liver failure from this treatment, which is really positive. And what's good to see is that even though, right, so we had 10% of the patients, the grade 3-4 adverse event was hypertension, presumably from the bevacizumab, and that's easy to control. And also to keep in mind, you know, because of the risk of bleeding with bevacizumab with patients with HCC, all of the patients had an endoscopy and could not have untreated varices going on the study. So fortunately, there was also not really a big risk of bleeding on this study, because that was another concern giving bevacizumab to this patient population. There were a couple of bleeding events, but they weren't varicose related. So ongoing development for this combination. So the FDA, based on the encouraging data that was seen, asked for another arm of the study to really see right before they approve a combination, because there really was very little Atezo alone data prior to this. But the suggestion was that Atezo alone was not nearly as active as this combination. So they asked for another arm of the study to randomize patients to the combination versus Atezo alone to really see if there was a synergy with the 2 drugs and that they would have to be approved as a combination. And so this arm is basically finishing up. But we don't have data to present on that yet. And then at the same time, a phase 3 study, the I Am Brave 150 study, open, looking at, in first line, randomizing patients to the combination versus sorafenib. So this is their registration study. And we don't have data for that yet, but what is exciting is that in the time that it took to complete Arm F, this study opened at a lot of centers, and the accrual is finished already. So we should be seeing data for that soon. So the study accrued pretty quickly. And then just thinking about some of the other combination studies that are going on. One of them is the Himalaya study. This is looking at durvalumab, another PD-L1 inhibitor, with tremelimumab, which is a CTLA-4 antibody. So of course, that's a combination that's used now in multiple other cancer types, including melanoma, with success. Overall, the trend is that it does increase response rate to add a CTLA-4 antibody to treatment, but it also increases adverse events. And so this study is looking at the single versus 2 regimens of different doses of the combination versus sorafenib, and that study has been, I think, accruing pretty well and should be finished soon. There's also other combination studies looking at TKI with immune therapy, and so that will be interesting to see. Overall, the discussion at meetings this past year has really centered around, so you have all these approvals, right? How are you sequencing things? Because so many studies were done as second-line therapy that you either, if you're giving sorafenib first-line or lenvatinib, how do you pick what to give next? Do you give immune therapy next? Do you give a second TKI next? Do you care about how long they were on the TKI in first line to think about the additional benefit of another TKI versus whether they progress quickly on a TKI? Thinking about immune therapy. I have to say, for me, it's been really exciting because we've never had a discussion before about how to sequence therapy in this disease. So to have options and have the argument about how to sequence things, what's most amazing is to have the discussion about if someone's responding well to immune therapy, when do you stop the treatment, right? So we've never had these conversations before for this disease, and that's been exciting. Now, Dan Pat mentioned a couple times that I was going to talk about molecular-driven therapy, and I kept thinking I'm going to disappoint him. Why am I not talking about that more? So the problem is, right, we have no biomarkers. So we know the mutational landscape of HCC, but none of the treatment that I mentioned has a biomarker to direct that therapy, right? So for tyrosine kinase inhibitors, right, we have no biomarker. Of course, we follow AFP levels for patients on treatment, and in general, I didn't show that data from the Atezo Bev study, but there's a very strong correlation with the AFP dropping off before we see response on imaging, because we're checking AFP levels more frequently than we're getting imaging. There is a correlation, right? But to pick patients to say who's going to benefit from therapy, we don't have a marker. I'd say the one marker we have really is high AFP from the ramucirumab study. And even PD-L1 status that might be used in some other diseases to select patients for immune therapy, there's no correlation for that for HCC, which means that we can give anyone then immune therapy to try, right? But we have no way of predicting who's that group that's going to do much better than the rest of the patients. So, we do know quite a bit about the mutational landscape of HCC. The problem is, if we look at some of these less common mutations here, right, these are the ones that we kind of have therapy for in other cancers, including other GI cancers, right? So EGFR, BRAF, KRAS, PI3 kinase, right? These mutations are very rare in HCC. So if we look at the ones that are in higher signaling, right, chromatin remodeling, et cetera, we don't have targets for that yet. So there are some drugs in phase 1 studies that are not necessarily specific to HCC that we have included in our phase 1 group at Yale, looking at maybe Wnt signaling inhibitor or chromatin remodeling. But I would say there's really no data yet to really show specifically, right, that we're seeing a signal in HCC and it's moving ahead with an HCC focus. So, hopefully in the next couple of years, right, we'll see more molecular targets come up. I do still strongly support, though, biopsying patients. And the truth is, as someone who treats all GI cancers, and although this is my first love, we biopsy everyone, and cancer patients expect a biopsy. That's kind of standard. They don't balk at getting the biopsy. I think, if we're thinking about patients who might be going to transplant or resection, you could argue about seeding, but in those patients, we wind up having tissue anyhow eventually because the tumor gets removed from them. But I think for patients that are in a more advanced setting where the seeding is not really an issue, I think it's important that we keep collecting this information, because often we do find mixed tumors that are cholangio HCC, and we really have to, that's a whole nother area that we don't really know how to optimally treat them. So I think it's important, but I have to say, I don't think we're really there yet where I can tell you that we have good data to say we're using the mutations that we're finding in each individual tumor and really focusing, right, molding their treatment around those mutations. So to come back to the slide that I started with, so before, right, this was the role of the medical oncologist in this narrow area. And now we have a lot more to add, right? So we have lenvatinib in first line, regorafenib, nivolumab, pembro, cabozantinib, ramucirumab, multiple combination studies that I think the initial data is promising, and I think there'll be some approvals coming along in the next couple of years. Very exciting. I think, though, now for me, the big interest in how do we take this data and the positive data that we're seeing, where even still a lot of it is just a small couple months survival benefit, and how do we enlarge that? And how do we think about the different groups? And how do we say that maybe this staging system, right, is not, that medical therapy should not be restricted to this one column here, right? So one big area of thinking is adjuvant therapy, right? So what do we do after resection? There was a study looking at sorafenib in adjuvant therapy, and it was a negative study. So patients got sorafenib or placebo after either resection or radiofrequency ablation that was done for cure, and there was no survival benefit, right? But we know now that there are other tumors, including melanoma, that there's a survival benefit of giving immune therapy after curative intent therapy. And so there are studies that are opening across multiple immune therapy drugs. So those studies, though, will take a long time, right? So the data won't be around for at least a few years for that. But that's one big area of interest. And then, of course, another big area of interest, as Julius brought up, right, there's multiple studies going on looking at the combination of local therapy and immune therapy. And that's of big interest, too, right? So how do we identify patients earlier? And could we be thinking about really moving the survival curve in a more meaningful way by getting patients, right, earlier in the treatment algorithm? And then I think another area is really looking at these drugs, and as they move to the real world and into the community, we're going to be treating, as we've been doing for years with sorafenib, we're going to be treating a lot of patients who would have never fit the criteria for the clinical trial, right? And then we may see a little bit more differences of really what combination or what sequence of combination works best. So thank you.
Thank you very much.